Chapter 12, Segment 2. Hi students, we're now going into the next segment of our lecture. In this segment we're going to be discussing sexual dysfunctions. I want you to first off understand that the DSM has three primary categories of sexual dysfunction. Disorders that involve desire, arousal, and interest, orgasmic disorders, and also sexual pain disorders. I want to draw your attention to this table, and this table does a really nice job of talking about the three major categories of sexual dysfunction, and then looking at both of those categories in men and women. When we see dysfunction of sexual interest, desire, or arousal in women, that's considered to be female sexual interest or arousal disorder. In men, that is male hypoactive sexual desire disorder. Remember, when you see that word hypo, that is less than or less than normal. In orgasmic disorder, that's called female orgasmic disorder. In men, that's erectile disorder. And in sexual pain, that dysfunction is called genitopelvic pain or penetration disorder in women, or premature ejaculation or delayed ejaculation in men. In order to get a better understanding of sexual dysfunction, we really do have to have a little bit of a handle on the sexual response cycle. When I'm talking about the sexual response cycle, I'm really talking about the work of Masters and Johnson. Masters and Johnson did research on sex in the 1960s, primarily in the 1960s, where they not just spoke to people about their sex lives, but also looked at individuals in the lab and looked at how they responded to sexual stimuli. And what they developed was called the sexual response cycle. So the sexual response cycle is made up of phases. The first phase is the desire phase. The desire phase just basically entails attraction, interest, that you are sexually attracted to a person, that you want to have sex with them, that you're interested in them. And the desire phase leads to the second phase, which is called the excitement phase. In the excitement phase, you get erection in the male, you get vaginal lubrication in the female, myotonia, which is muscle tension, increased heart rate. Those are some of the characteristics that go along with the excitement phase. In between excitement and orgasm is the plateau phase, which is considered an advanced state of arousal. It's that state of arousal that precedes orgasm. You're getting an increase in vasocongestion, which is swelling of the genital tissue, increased muscle tension, increased heart rate, increased blood pressure, all in preparation for orgasm. The third phase is the orgasm phase. Both orgasm in men and women are marked by muscular contractions. Basically, in men, you're going to see contraction of the vas deferens, seminal vesicles, ejaculatory duct, and the prostate gland. In women, you're going to see contractions of the pelvic muscles that surround the vaginal canal. About 3 to 5 contractions at 0.8 second intervals. And generally, then this is followed by some weaker contractions. During orgasm, blood pressure and heart rate have a tendency to peak out. After the orgasm phase is the resolution phase. During the resolution phase, men lose their erection. This usually happens in 2 stages. In the first stage occurs as blood rushes out of the penis, and in the second stage everything goes back to normal size. In the female, everything just returns to normal size, and the sex flush just rapidly disappears. There's another phase called the refractory period. And the refractory period follows the resolution phase. And it's the time during which a person is physically unable to achieve another orgasm. The length of refractory can vary by person and can be dependent on sex. So women have a tendency to have a very shorter refractory period than men do. And it is thought that this shorter refractory period is what allows them to be multi-orgasmic. Men, on the other hand, when they are young, have a tendency to have a shorter refractory period than when they are older. Once they start to get into their 20s and 30s, the refractory period becomes longer and longer. It lengthens into their 40s and as they continue to age. So it takes more time for them to become physically aroused. It takes longer. When they're young, it doesn't take very long. When they're 18, 19, 20, it doesn't take very long. When they're 70, it takes a lot longer, a lot more time in between those orgasms. So it's important to understand a little bit of context with the sexual response cycle in order to help us understand or be able to think about any sort of sexual dysfunction a person might have. When we look at self-reported rates of sexual problems in the past 12 months, we do see some variability between men and women, particularly in lack of interest in sex. And it does seem to be fairly consistent even when we control for things like culture. We do see some difference in inability to reach orgasm between men and women, with, again, women reporting higher rates as opposed to men. So let's talk a little bit about some DSM criteria for sexual interest or arousal disorder in women. When we think about the DSM is going to set up for us what main points need to be hit in order for the diagnosis to be given. So when we think about arousal disorder in women, what we're really looking for is a diminished, absent, or reduced frequency of at least 3 of the following for 6 months or longer. So we're looking for particular characteristics, a particular number of characteristics, and for a certain length of time. Diminished interest in sexual activity, a diminished level of sexual or erotic thoughts or fantasies, a lack or diminished initiation of sexual activity or responsiveness, absent or reduced sexual excitement or pleasure during 75% of sexual encounters, a lack of or reduced sexual interest or arousal elicited by any internal and external erotic cues, and then a lack of or reduced genital or non-genital sensations during 75% of sexual encounters. A couple other things to keep in mind is that it has to cause a marked distress or interpersonal problems, and it's not due to a medical illness or any other psychological disorder or the effect of a medication. When we consider the criteria for hypoactive sexual disorder in men, we are looking for a deficiency or absence of sexual fantasy or desire. We're looking for marked distress, or that this is causing interpersonal problems in their relationship. And we need to understand that it's not due to a medical illness, a psychological disorder, or an impact of another medication. When we consider the criteria for male erectile disorder, on at least 75% of sexual occasions, there is an inability to attain an erection, an inability to maintain an erection, a decrease in erectile rigidity that interferes with penetration or pleasures, and again, not due to medical illness, psychological disorder, or the impact of drugs. When we think about the criteria for female orgasmic disorder, what we're looking for on at least 75% of sexual occasions, a delay in frequency or absence of orgasm, a reduced intensity of orgasmic sensation, and that it causes distress or interpersonal problems. And again, as with any of them, it's not due to medical, psychological, or medications. I do want to take a couple minutes here to talk a little bit about female orgasm, that some of the research to keep in mind when thinking through about whether or not to give this diagnosis, that there is a difference between clitoral orgasm and vaginal orgasm, and that there's a lot of discussion as to the validity of vaginal orgasm. About less than 30% of women report having vaginal orgasm. And what anatomy tells us is the vagina is not sensitive. It's not a sensitive organ, and it's not constructed to reach orgasm. The vagina is really constructed to deliver babies. So in one piece of research done by Kinsey, where he actually had the vagina, he touched women's vaginas with a speculum, less than 14% were even aware that they had been touched. With some people, you can perform surgery without the anesthesia. It's simply not an organ that is constructed for orgasm. It's not a sensitive organ. The clitoris is really the center of sexual sensitivity for women, and its corollary is the penis. It's composed of erectile tissue, and it's covered by the epithelium and genital corpuscles. So for most women, what research tells us is the center of sexual pleasure, or the center of orgasm, really is the clitoris. And so if you're dealing with a client or talking with someone who is reporting some issues with female orgasm, this is a direction or conversation that you might want to consider with this client, having them understand the difference here. All right, what about our criteria for delayed ejaculation? What we're looking for is a marked delay, an infrequency or absence of orgasm in at least 75% of sexual occasions. It causes distress. It causes interpersonal problems. Criteria for premature ejaculation: tendency to ejaculate during partner sexual activity within 1 minute of penile insertion on at least 75% of sexual occasions. Again, it's causing marked distress or interpersonal problems. And as I said before, what we're looking for are problems that are not due to medical illness, due to other psychological disorders, and they're not the cause of medication. All right, the last category of sexual dysfunction that we're going to be discussing are sexual pain disorders. In the DSM-5, these are categorized as genital pelvic pain or penetration disorders. They are persistent or recurrent pain during intercourse. While it's diagnosable in both men and women, we rarely see it in men. This is a diagnosis that is given when there is an absence, when there is no medical cause. So there's no infection, there's no menopausal problems, any of those things. In the DSM-4, this was originally called vaginismus or dyspareunia. That was the original diagnosis or title given. Now they're called sexual pain disorders. So earlier on in this segment, I talked a little bit about Masters and Johnson work, their research looking at the sexual response cycle. And when thinking about human sexuality or thinking about sexual encounters between individuals, they identified both immediate and distal causes that can contribute to sexual dysfunction. So I'm going to take a second here. I want to look at the distal causes first. So these are all the things that can happen before a person gets into a situation where they're going to engage in sex. Guilt from religion, religious mores or cultural mores, a past history of rape or sexual abuse, having a lack of knowledge about sex, physiological problems, sociocultural factors, any of these sorts of things, anything that you might feel guilty about or that might impact that encounter. These are considered distal causes or distal factors, and they lend themselves or can create a spectator role. In other words, that a person is not an active participant. They're not participating in the moment. They're not in the moment. It's as if they're watching it. It's as if they're watching it. And this can create, in the immediate causes, sort of being unplugged from the act, and can lend itself to sexual dysfunction. When we think about the etiology of sexual dysfunction, the first thing I want to discuss here are some of the biological factors. The DSM-5 includes separate diagnosis for sexual dysfunctions that are caused by medical illnesses. Now this is somewhat controversial because many sexual dysfunctions have a biological contribution, and so it's been very challenging to sort of tease this apart. What role do these biological factors play? And then does interpersonal therapy or talk therapy lend itself to sort of helping? So this has been a little bit of a challenge when we think about sexual dysfunction. But what are some of these biological factors or diseases that can contribute to sexual dysfunction? Well, things like diseases of the vascular system, diseases of the nervous system, low levels of testosterone or estrogen, drinking heavily, chronic alcoholism. Drinking too much can impede arousal, can keep a person from getting sexually aroused. Smoking too much can keep a person from being able to become sexually aroused. And then various medications can have impact. SSRIs and antihypertensives, those can add to a person's inability to become sexually aroused. Some of the psychosocial factors can include things like rape, early childhood sexual abuse. These things, having a bad experience, having a bad sexual experience early on, can impact the way a person relates to sex later on as an adult. Relationship problems are a major contributor to sexual problems within a marriage or a ongoing or long-going relationship. A lot of anger or hostility, buried hostility, poor communication between partners. All these things can become underlying issues to a lack of desire or sexual interest in their partner. Some psychological disorders can be contributors: major depression, anxiety, panic disorder. They can all contribute to a person's inability to have an interest in sex or to be able to become aroused. Stress and exhaustion, or even negative cognitions. Engaging in a pattern of negative thinking doesn't set one up to have a positive sexual experience. So what are some ways that we treat sexual dysfunctions? As I mentioned before, we know that for many sexual dysfunctions, some of the major contributors are physiological or biological in nature. And often when you address the physiological or the biological, it seems to work through or correct the sexual dysfunction. And sometimes other treatment modalities become really unnecessary. But sometimes the physiological contributor can cause that person to be stuck. And sometimes introducing another treatment modality in addition to addressing the physiological problems can sort of help that person work through it a lot more efficiently. So what are some of these treatments? Reducing anxiety, going through some anxiety reduction, addressing the anxiety the person might feel in a sexual encounter. Directed masturbation. Procedures to change thoughts and attitudes, using sensory awareness procedures or rational emotive therapy. Really talking to a person about addressing guilt or negative thoughts, or addressing guilt or any negative thought that they might have about sex. Having them sort of become that active participant or living in the moment, becoming more aware of what's going on, right? Having sensory awareness of what's going on in the encounter rather than thinking about any sort of negative emotion or attitude that they might have. Sexual skills and communication training. Really, this lends itself back to relationship skills, relationship training, couples therapy, working on the problems within the relationship or within the marriage in order to help address the sexual problems. So you're working on that hostility or the anger or the resentment that might be building up emotionally in order to be able to get them closer emotionally and sexually. Medications and physical treatments. Different techniques such as the squeeze technique for early ejaculation, PDE5 inhibitors for erectile dysfunction, things like Viagra, Cialis, and Levitra can help with things like erectile dysfunction.